Attention deficit hyperactivity disorder, also known as ADHD. I'm going to review the criteria in order to render a diagnosis of ADHD. And I want to point your attention to the fact that there is only a diagnosis of attention deficit hyperactivity disorder. There is not a diagnosis of attention deficit disorder, and we're going to talk about these differences here when we look at the criteria. I point this out for the sake of accuracy. It doesn't mean you need to go and correct someone when they say ADD or attention deficit disorder. You don't need to correct them and say, no, there's no ADD, there's only ADHD. Because we know what they mean. When they say ADD, it essentially means there's no hyperactivity present. But for the sake of accuracy, there is only a diagnosis of ADHD, and it can be either inattentive type, hyperactive type, or both. So let's look a little closer at this. This is on page 59 of your DSM-5. So you see the diagnostic criteria for ADHD. Part A, a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development as characterized by 1 and or 2. So it can be 1 and 2, or just 2. So 1 is the inattention. So if they meet only this type, then it's the inattentive type. In order to have the inattentive type, there needs to be 6 or more of the following symptoms that have persisted for at least 6 months to a degree that is inconsistent with developmental level. That's important. So there's age-appropriate behavior as well. So this needs to be to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic or occupational activities. So there's that disclaimer that I mentioned when reading the ADHD that people can have symptoms, but unless it negatively impacts their social and academic or occupational activities, and there's no need to render a diagnosis. There is a note here that symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or a failure to understand tasks or instructions. For older kids and adults, at least 5 symptoms are required. So if they're under age 17, you need 6. If they're age 17 or older, you only need 5 symptoms. So point A, this is one, you'd have to have 6 of these or 5 of these depending on the age in order to meet the criteria for the inattentive type. So A, often fails to give close attention to details or makes careless mistakes in schoolwork or at work or during other activities. Some examples: overlooks or misses details where the work is inaccurate. Point B, often has difficulty sustaining attention in tasks or play activities. Example, having difficulty remaining focused during lectures, conversations, or lengthy reading. Point C, often does not seem to listen when spoken to directly. Mind seems elsewhere, even in the absence of any obvious distraction. And that is a point I like to refer to as hyper-focusing. So a person could be distractible, but they can also hyper-focus to the point to where their attention is so focused that they just don't seem to recognize when being called. D, and hyper-focusing is not such a bad thing. D, often does not follow through on instructions and fails to finish schoolwork, chores, or other duties in the workplace. Starts tasks but quickly loses focus and easily gets sidetracked. Point E, often has difficulty organizing tasks and activities. So this could be difficulty managing sequential tasks, difficulty keeping materials and belongings in order, is messy, disorganized, has poor time management, fails to meet deadlines. So lots of kids could meet that criteria. Point F, often avoids, dislikes, or is reluctant reluctant to engage in tasks that require sustained mental effort. So they'll be a little bit avoidant when it comes to schoolwork or homework. For the older kids, could be reluctant to prepare reports, complete forms, review lengthy papers. Just averse to it, as a probably because of the history of being unable to require sustained attention. G often loses things necessary for tasks or activities, school materials, pencils, books, tools, and so forth. H is often easily distracted by extraneous stimuli. For older kids, it could be just unrelated thoughts that are projected. I is often forgetful in daily activities, forgets to do chores, run errands. Older adolescents and adults, it could be returning calls, paying bills, keeping appointments. So you would need to meet 6 of these. If a child, 5 if an adult. Does not have to be all of these together. It just needs to be 6 or 5. So we're going to move on to point 2. That was the inattentive type. And we're going to, again, talk about that a little bit more further down this page. Now, the second type is the hyperactive or impulsive type. Again, 6 or more of the following symptoms for at least 6 months, inconsistent with developmental level, and most importantly, negatively impacts directly on social and academic or occupational activities. And again, the little disclaimer. So, 6 or 5 of these. A, often fidgets with or taps hands or feet or squirms in seat. B, often leaves seat in situations when remaining seated is expected. Leaves their place in the classroom or the office or the workplace, needs to move around. C, often runs about or climbs in situations where it is inappropriate. So in adolescents or adults, this may be limited to just feeling restless. D, is often unable to play or engage in leisure activities quietly. It can be a little boisterous. E, is often on the go, acting as if driven by a motor. This is an expression or description that has been consistent in versions of the DSM. I just think it's an interesting way to describe behavior that, and it probably makes sense if you've been around somebody like that. It's just like they're the Energizer Bunny. They just keep going and going. They're really unable to be or uncomfortable in being still for an extended time. Could be restaurants, meetings, may be experienced by others as being restless or difficult to keep up with. It's probably one of the prototypical symptoms for this hyperactive type. F, often talks excessively. G, often blurts out an answer before a question has been completed. Might complete other people's sentences, can't really wait for their turn in conversation. So this is a nod to behavior being impulsive as well, not just perhaps the hyperactivity that we see in these points, but it's an impulsivity is another strong characteristic of this type. H, often has difficulty waiting for his or her turn. I, often interrupts or intrudes on others, butts into conversations, games, activities, start to use other people's things without asking, may intrude into or take over what others are doing. So points G, H, and I are more focused on the symptoms of impulsivity. So those are the 2 types. So you were seeing that we were looking at points 1 and 2 under A, and so now we're moving on to B. Several inattentive or hyperactive impulsive symptoms were present prior to age 12. So this is a major issue, particularly when you encounter adults who might claim or profess to have ADHD, is that according to the DSM, in order for this to be really ADHD, it would need to be present before the age of 12. There's got to be a history there. Point C, several inattentive or hyperactive impulsive symptoms are present in 2 or more settings. So it has to be at home and school, or at home and work. Um, I'm sorry, I'm misrepresenting this. It needs to be in this, at school, home, or work, and it needs to be present with friends or relatives, which I guess is, in a way, kind of synonymous, but I would probably interpret this as it needs to be at home and one of these 2 locations. It can't just be at school, for example, that the child displays these types of symptoms. That's probably the most common occurrence of when you're trying to discern this particular issue is when you're working with a child. If it's only happening at school and it's not being noticed by parents, by friends, by other situations, team sports, or whatever the case might be, if it's only school, then this criteria may not be met. Point D, there is a clear evidence that the symptoms interfere with or reduce the quality of their life in social, academic, or occupational functioning. Point E, the symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder such as a mood disorder, anxiety, dissociative, and so forth. This point is probably gone into a little more detail in the differential diagnosis section, but just briefly, someone with depressive disorder might be fairly distractible and might have difficulty concentrating, and so you really have to kind of rule out that other things are going on with the child in particular in order to accurately assess ADHD. So here's the specifiers, and this is where you really look at what type of ADHD it is. So 314.01 is considered the combined presentation. It is both inattentive and hyperactive impulsive type. This is probably what you encounter the most when it's true ADHD, that the individual is going to be both inattentive and distractible and hyperactive. It's probably the thing that gets noticed the most. Now, the predominantly inattentive type is where that thing I mentioned before about people referring to ADD, or attention deficit disorder. This is really what they mean, and the true title of this is 314, Attention Deficit Hyperactivity Disorder, predominantly inattentive presentation. That's the full diagnosis there. But, in kind of lay terms, the way people typically describe it is just ADD, or attention deficit disorder, but this is the accurate way to label it. 314.01, you'll notice, is similar to this code. There is a separate code here. I believe these are the ICD codes. And you can read more about that in the DSM. This is a predominantly hyperactive impulsive presentation. Personally, I don't know that I've really ever encountered this clinically, where I'm able to really tell that a child is hyperactive impulsive and at the same time not inattentive and distractible. I think that would be pretty difficult to specify. So this may not be something that you commonly encounter, the predominantly hyperactive impulsive presentation. You also need to specify if it's in partial remission when full criteria were previously met. Fewer of the full criteria have been met for the past 6 months. Symptoms still result in impairment in those areas. Probably don't encounter that too much. And then you can talk about some severity, and there's more information on that in the DSM, and I don't necessarily need to go into that. Well, let's talk about assessing ADHD. There is no issue in my mind that a good clinician, someone who has experience with ADHD, treating ADHD, that just through clinical observation and interview with various parties, that you can probably determine an accurate diagnosis But in most cases, when you're working with kids, the interested parties are going to want a formal evaluation, particularly if medication is going to be discussed, and so you're probably going to need to engage in participate in some type of formal observation. And most of these instruments that you'll find for ADHD are going to be licensed instruments, and you'll need to have purchased copies to be able to use them. As a clinician, I was able to purchase ADHD workbook. I think it was written by Barkley, who's a big name when it comes to ADHD and diagnosing ADHD. And I was able to get it fairly inexpensively to get this packet. And the workbook had rating forms that I could use, copy, and use. It was licensed to do that. I was able to make copies and send them out if needed. In most cases, particularly you that are school counseling focused, you're going to have a school psychologist on staff, and they're really going to handle all of the rating forms. In other cases, you might have a child that comes to school and the pediatrician has given them some rating forms that need to be completed, and they'll give them to the teacher. Might have conversations with you. So there won't be many times as a counselor, practicing counselor, that you'll need to engage or initiate this formal assessment process. You're going to be given copies of these forms from other professionals to be completed. And let me make sure I'm getting this thing working correctly. There we go. So you won't have to come up with these things on your own, but I am going to go through a couple of them just so you understand essentially how they work. Some of the more popular ones. This is from a website called the ADHD Institute. You can see the web address up here if you want to visit this on your own. This is the primary website, and then you can get to this page through a couple of links. And these are some samples of child and adolescent scales. And these are, you can see in the categories in symptoms, categorized by symptom scales. These are scales that will essentially be checklists, rating scales that are based on the symptoms that we just reviewed in the DSM. Some other ones are going to be a little more in-depth when it comes to executive functioning and other types of scales. We are going to perhaps look at the Achenbach CBCL. I might pull this one up, and then the Connors I'm not going to pull up because there's not an actual copy of the instrument here, but that's going to be one of the more popular ones that you will run into. So the Connors and the Achenbach are probably the two most popular ones that I have seen in practice. Now the procedure when it comes to formal assessment is that there's going to be multiple versions of the assessment distributed. There's going to be one for the child, depending on their age. There's going to be one for the parents or caregivers. And there's going to be one for the teachers that need to fill out. And all these are filled out and sent back to whoever is conducting this assessment, and then they provide the analysis and the interpretation. So let's first look at the Achenbach here, the CBCL. It gives you, for this website, it gives you a brief introduction of what it's like. It gives you overview, scoring, who it's used for, things like that. And then it gives you a link with some of these to be able to take a look at it. Let me see if I can get this to pull up here. Here we go. So this is the Achenbach CBCL Child Behavior Checklist. And I have pulled up the wrong one. This is the 1.5 to 5-year-old. I wanted an older one. Child and Adolescent Symptom Scale. Bear with me just a minute here. I might have bookmarked the older one. Here we go, 6 to 18. I probably found this on the website for the Achenbach. It's not wanting to cooperate. Oh well. We'll take a look at this younger child version, and that'll at least give you a brief introduction of what it looks like. So the one I was trying to pull up is designated for kids age 6 and beyond, 6 to 11. This one is for ages 1.5 to 5. So this is a population that you're probably not going to work with. And in my opinion, I would not even, as a clinician, I would not even entertain the idea of trying to diagnose ADHD with a child before they are in school. It would be fairly difficult to make some type of determination in my opinion. Number one, because of the setting that they're in. Most settings that a preschooler is going to be involved in don't require lengthy periods of time in which they need to sit still or pay attention. It's also age appropriate for a young preschool child to be distracted, to be unable to focus for extended periods of time. The brain is not yet fully developed, and therefore I would not recommend trying to diagnose a younger child with ADHD. But this at least gives you a perspective of what the rating scale will look like. It will talk some about who you are. This is for the parents, this particular form. So it gets them to describe who they are, to identify who they are. And then this particular form is a little shorter than the older adolescent one. This one gets right into the symptom ratings. You can see it's fairly simple. Just rating not true, somewhat or sometimes true, and then very true or often true. This is similar to the older kid version. And a lot of these things that you see listed here are not specific to ADHD. This is, by being a behavior checklist, it's assessing lots of different things. But it does try to examine ADHD symptoms. So I'm trying to find some of those elements. Can't concentrate, pay attention for very long. This is one of them. Can't sit still, restless or hyperactive. Can't stand waiting. Let's see. What I'm looking at right now, I'm not seeing any particular ones that would be symptoms from the DSM. In particular, I can see that they're trying to assess lots of different things. It's difficult to look through these. You can see how the items are alphabetized by the first word in the item. It's kind of unique in that way, but I'm sure they intentionally did it that way so that it wouldn't be completely obvious as to what is being assessed with particular items. So, for example, if they categorized all the items related to ADHD, then it would be a little more apparent to whoever's taking this assessment as to what it's trying to get at. So that's why it's probably categorized this way. All right. Well, I'm not looking through this real carefully, but just at casual glance, I'm not noticing too many more items. So maybe it wasn't such the greatest idea to go through this younger child version of this assessment. The older adolescent one probably has a few more items when it comes to diagnosing ADHD. But really the point that I wanted to make is that these symptom checklists, like the Achenbach, you can pretty much see that when you're looking at items that it's really the categories from the DSM that they're really looking at, trying to have people to specify checking those off to be able to determine if it supports a diagnosis. So that's really all these are. These formal assessments that you'll get could essentially and almost be recreated by you with just some of the symptom checklists, um, asking some of the same questions that you might get at when looking at DSM criteria. So let's look at another one, and this might be a little more helpful to be able to see how these checklists really are a nod to the DSM. All right, this is probably a little bit better. This is an instrument that would be sent home to a parent or caregiver. You can see point 1, fails to give close attention to details, makes careless mistakes in schoolwork. 2, fidgets with hands or feet, squirms in seat. I won't read through all these, but you can see these are really reworded, almost reworded identical criteria from the DSM. This form even gives you information about how to score. And helpful issue is that it gives you the scoring sheet on the back page. You see it says for healthcare provider interpretation only. There are norms for females and then norms for males. You'll notice in the DSM that males have a higher prevalence rate with this particular diagnosis. Alright, so this was the ADHD rating scale 4, the home version. I think that's it. Maybe I will click on the Connors to see what it says. It probably would be helpful to take a look at this if you want to, just to give you some understanding about who this is used for and strengths and things about this particular assessment. You see that it's linked to Pearson Publisher, so you click on that link and it'll take you to the page where you can order these assessments, and it's going to be in the hundreds of dollars, several $100s that you would need to pay in order to get licensed to use these particular assessments. So I believe that's it in terms of what I wanted to cover with ADHD. In summary, in looking at the DSM and these assessments, when you're trying to make your own informal assessment as to the kids you might be working with, is use the DSM. Think about the symptoms that are necessary to be endorsed in order to meet this diagnosis. That's really what you would be looking at if you were using a formal assessment anyway. Just think about how it's worded in the DSM and how you might ask very pointed, particular questions to get at those same symptoms.